This video explores the groundbreaking work of neurosurgeon Dr. Isadore Tarlov, who discovered sacral Tarlov cysts. If you're a patient, you've likely come across his name. But what if I told you that his research is far more fascinating than you may have been led to believe? We'll uncover the truth behind his discovery, research, and advocacy efforts to support patients living with this debilitating condition. Thank you for watching, and I hope you enjoy uncovering the untold story of Dr. Isadore Tarlov. In 1938, neurosurgeon Dr. Isadore Tarlov performed dissections on cadavers to better understand the anatomy of the lower spine, and a specific structure called the filum terminale. During these dissections, he discovered cystic lesions on the sacral nerve roots of 5 cadavers. These cysts were located on the posterior, backside of the sacral nerves, where they exit the dural sac and transition into the extradural space. This discovery was significant because these lesions in the sacral spine had never previously been described in medical literature before. Dr. Tarlov was familiar with several medical reports published between 1898 and 1937 that described various cystic lesions in the thoracic and lumbar spine. Among these, he identified the cysts documented by Dr. Marburg in 1902 and Dr. Heinrichs in 1932 as most closely resembling the sacral cysts he had just discovered. The cysts were found on the S2, S3, S4, and S5 nerve roots, ranging in size from as small as a pinhead to about 2 centimeters. Dr. Tarlov noted that all but one of the cysts appeared to be sealed off from the subarachnoid space. When examined under a microscope, the cysts contained clear or slightly yellow fluid. Their walls were made of thin layers of arachnoid or perineural cells wrapped in delicate connective tissue. He also observed immune cells, suggesting a possible inflammatory response within the nerve root sheath. Additionally, there was evidence of degenerative changes in the nerve fibers, ganglion cells, and disintegrated myelin sheaths. Dr. Tarlov concluded that the cysts formed in the perineural space, which is located between the inner and outer protective layers of the nerve roots. Later that same year, Dr. Tarlov published a paper titled Perineural Cysts of the Spinal Nerve Roots to share his new discovery with the medical community.
The reason for the apparent predilection of these cysts for the sacral nerve roots is not clear. Although the cysts appeared to be without clinical significance in these cases, one wonders whether they may not be responsible for the discomfort in certain cases of sciatica or nerve root pains in which any other pathologic basis has been excluded. This awaits further studies with clinical and pathologic correlations. The clinical significance of these cysts remains to be determined.
In 1948, Dr. Tarlov published his second paper called Cysts, Perineural of the Sacral Roots, another cause of sciatic pain. In this publication, he confirmed his earlier theory from 1938 that Tarlov cysts could indeed cause symptoms. J.L., aged 42, was the first living patient Dr. Tarlov met with a symptomatic Tarlov cyst. On Christmas Day in 1946, J.L. tripped and fell at home, striking her head, lower back, and hip against the hearth of her fireplace. She suffered a bump on her head and bruises on her right hip and lumbosacral area. Over time, her pain worsened significantly. Everyday activities like sitting, bending, getting in and out of bed, and completing housework became increasingly difficult. 6 months after her fall, the pain began radiating down the back of her right thigh. She found only brief relief from lying down and applying heat. Along with the pain, she developed a sensation of pressure, warmth, and numbness that stretched from the back of her right hip down to her calf. During JL's physical examination, it was noted that she felt increased pain in her right thigh when her back was bent backward and tilted to the right side. Additionally, she had reduced or absent movement and reflexes in her right ankle and foot. On August 30th, 1948, an exploratory surgery was performed to investigate the possibility of a herniated disc, but none was found. Dr. Tarlov observed epidural fat pushing out from beneath the sacrum. He removed 3 centimeters of the right sacral lamina and discovered a cystic lesion on the S2 nerve root, measuring 2 centimeters long by 1 centimeter wide. The cyst was not connected to the subarachnoid space and had a narrow neck. Dr. Tarlov removed the cyst along with a portion of the nerve root. Following the surgery, JL's sciatic pain, as well as her motor and sensory issues, showed significant improvement. After 1 week of bed rest, her foot strength and sensation were normal. 2 months later, JL was able to carry out all her household tasks, but mentioned experiencing occasional mild, brief pain at the back of her right thigh. The only abnormal finding during her follow-up was the absence of the right ankle reflex, but she did not feel hindered in any way. In his 1948 research paper, Dr. Tarlov concluded that perineural cysts arising from sacral nerve roots can cause sciatic pain, but are often overlooked during standard interlaminar exploration unless the back portion of the sacrum is removed. He noted that these cysts are more common than previously recognized and may explain unresolved sciatic symptoms when herniated discs are ruled out. Dr. Tarlov emphasized that surgical exploration of the sacrum in such cases could improve diagnostic accuracy and treatment outcomes. In 1952, Dr. Tarlov published his third paper, titled Cysts of the Sacral Nerve Roots: Clinical Significance and Pathogenesis. He makes the following statement at the beginning of the paper.
Most of my dissections disclosing cysts were done in the anatomical laboratory on cadavers with incomplete records. How many of these lesions were accompanied by symptoms is therefore unknown.
In this paper, he detailed the accurate diagnosis and surgical treatment of symptomatic perineural cysts in 2 patients in 1950 and 1951. This is impressive considering the MRI machine would not exist for another 30 years. The first case from 1950 involved a 28-year-old man who presented with groin, left thigh numbness, and urinary incontinence. Before seeing Dr. Tarlov, the patient underwent unnecessary surgery by another physician to address a suspected herniated L4-L5 disc, which failed to resolve his symptoms. Over time, his condition worsened, with increasing numbness, sexual dysfunction, and loss of the right ankle reflex. Dr. Tarlov suspected the presence of perineural cysts. During surgery, 2 cysts were discovered bilaterally on the patient's S2 nerve roots. The right cyst, along with a portion of the ganglion, was removed, while the left cyst was punctured for drainage. 13 months after surgery, the progression of symptoms had stopped, and the patient's bladder symptoms had resolved. However, some numbness and the absent ankle reflex persisted. Dr. Tarlov speculated that additional, smaller, undetected cysts on other nerve roots might have contributed to the remaining issues. The second case, from 1951, involved a 70-year-old woman who experienced tingling in the groin and down her right leg to the heel. Her symptoms worsened when lying down or sitting, and firm pressure on the sacrum caused tenderness. She also displayed weakness in her right foot. During surgery, Dr. Tarlov identified 4 cysts on the S2 and S3 nerve roots. To minimize complications, only the domes of the cysts were removed. The largest cyst on the left, S2 nerve root, had compressed the dural sac and nerve roots. Post-operatively, the patient experienced improved right foot strength and resolution of tingling in her left leg, although tingling in the groin persisted. Dr. Tarlov also discussed 2 cases of female patients with high blood pressure who suffered subarachnoid hemorrhages that ultimately led to death. Autopsies revealed both old and new hemorrhages in the sacral nerve roots, along with cysts. He theorized that some cysts may form as a result of damage from subarachnoid hemorrhages, where the absorption of destroyed nerve tissue and blood contributes to cyst formation. Dr. Tarlov concluded the paper by suggesting that perineural cysts should be considered when patients have gradually worsening symptoms related to the sacral nerves, and when surgery fails to identify a herniated disc as the cause of sciatica. Dr. Tarlov published a monograph in 1953 titled Sacral Nerve Root Cysts, Another Cause of the Sciatic or Cauda Equina Syndrome. This was a specialized book where he extensively documented his discovery of sacral Tarlov cysts, explaining their pathology, symptoms, surgical techniques, and outcomes, combining in-depth scientific research with case studies. This monograph is rarely spoken about. Dr. Tarlov explained the purpose for writing this book.
As physicians become more aware of the existence of these cysts, more of them will doubtless be found. The purpose of the present monograph is to sharpen this awareness by spreading knowledge of the cysts. Patients hitherto thought to be suffering from obscure or even psychological ailments, but actually harboring cysts will thus be given relief.
Remarkably, Dr. Tarlov used the very cover of his book to emphasize why a wide range of medical specialists should take an interest in perineural cysts. He highlighted the multifaceted nature of these cysts and their potential to cause symptoms affecting various systems. He attempted to urge collaboration among specialists to better diagnose and treat patients with these lesions. Sadly, 71 years later, Present-day symptomatic patients are treated extremely poorly by the medical community. This will be discussed later on in the video. Notably, Chapter 8 of the book is titled Clinical Significance, where he went into detail describing 10 different patient case studies, spanning between 1948 and 1952. Dr. Tarlov personally operated on 4 of the 10 patient case studies. The remaining 6 cases were performed by different doctors using various techniques. He details their age, symptoms, neurological findings, history of physical trauma, surgical techniques, and outcomes. Dr. Tarlov's clinical summary indicates that the 10 case studies revealed patients often presented with painful symptoms resembling sciatica, sensory disturbances in the gluteal and groin regions, and urinary issues. Symptoms were progressive and persisted for durations ranging from 8 months to 20 years. Physical trauma, such as falling, heavy lifting, or car accidents, was reported in 40% of cases. Most of the cysts were located on the S2 nerve roots, with sizes ranging from 5 millimeters to 3 centimeters. Surgical outcomes showed that complete removal of single cysts typically resulted in full recovery. In contrast, cases involving multiple cysts often experienced only partial symptom relief due to a more conservative surgical approach to avoid post-operative complications. Dr. Tarlov ended his book with some of the following points.
The results of surgical treatment of sacral perineural cysts are gratifying. They justify intensive clinical efforts to identify the symptoms and signs of this removable cause of sciatic and sacrococcygeal syndromes. Because of the manifold symptoms caused by sacral perineural cysts, patients consult or are referred to neurologists, psychiatrists, urologists, orthopedists, or gynecologists. As clinicians become increasingly aware of sacral perineural cysts, the number of recognized cases will doubtless increase.
In 1970, Dr. Tarlov published his final paper, Spinal Perineural and Meningeal Cysts, which focused on differentiating between various spinal cysts. He detailed the challenges of diagnosing perineural cysts using myelography. This diagnostic imaging technique involves injecting contrast dye into the subarachnoid space to visualize the spinal cord, nerve roots, and surrounding structures. Dr. Tarlov noted that perineural cysts often exhibit limited communication with the subarachnoid space, preventing the immediate entry of contrast dye into the cysts and making them difficult to detect on initial imaging. To address this issue, he recommended leaving some of the contrast dye in the spinal canal and performing delayed imaging to identify any perineural cysts that might have filled with dye over time. The following photos are an example of delayed myelography filling of perineural cysts. The first picture shows a normal myelogram, with no visible cysts in a 46-year-old patient who suffered from sacrococcygeal and buttocks pain for 9 months. This second picture was taken 3 months later, finally showing the existence of her symptomatic perineural cysts. So to recap what we have learned so far in this video, 1938. Dr. Tarlov first identified sacral perineural cysts during autopsies. These cysts were found in deceased individuals with incomplete medical records. Based on his findings, he hypothesized that these cysts might be capable of causing symptoms. 1948. Dr. Tarlov confirmed his hypothesis by successfully treating a woman with a symptomatic S2 cyst through surgery, establishing a direct link between perineural cysts and symptoms. 1952. He documented the ability to diagnose symptomatic Tarlov cysts in 2 patients before surgery. In this publication, he emphasized the clinical significance of these cysts and the need for accurate diagnosis and treatment. 1953. Dr. Tarlov published a comprehensive book detailing his research on Tarlov cysts. The book included extensive documentation of the cyst's symptoms, diagnostic approaches, treatments, and surgical outcomes. He aimed to share this knowledge with the medical community to improve patient care. In 1970. In his final publication, Dr. Tarlov focused on the importance of proper diagnostic techniques, particularly using myelograms, to identify and differentiate these cysts accurately. Despite Dr. Tarlov's dedication to advancing knowledge about perineural cysts through 4 research papers and a comprehensive 134-page book, progress for symptomatic patients has been limited over the past 86 years. While he likely envisioned a future with increased awareness and improved diagnosis of symptomatic Tarlov cysts, many patients today continue to face significant barriers, including misdiagnosis, dismissal of their symptoms, and inconsistent recognition of this condition within the medical community around the world. Education about Tarlov cysts remains minimal in medical training, despite decades of growing research. This is across the board for all specialties in medicine. Many doctors continue to tell symptomatic patients their Tarlov cysts are asymptomatic or incidental, despite their symptoms of nerve compression and sacral radiculopathy. Among those contributing to this dismissal, MRI radiologists play a significant role. They often omit the existence of the cysts on imaging reports or insert dismissive terminology such as asymptomatic, incidental finding, or of no clinical significance. This practice causes a trickle-down effect, setting in motion the dismissal and misdiagnosis that will be applied to patients. Instead of dismissive terminology, MRI reports should focus on clearly documenting the presence, size, and location of the cysts, leaving it to the treating physicians to decide how they relate to the patient's symptoms. For comparison, radiologists do not label findings like herniated discs, spinal stenosis, or fractures as incidental or asymptomatic. They simply state them on the report and let the doctors determine their relevance to the patient's symptoms. As early as the 1950s, Dr. Tarlov recognized that patients with symptomatic cysts were often misdiagnosed. Over 70 years later, misdiagnosis remains a significant issue. Today, many patients are incorrectly diagnosed with conditions such as fibromyalgia, functional neurological disorder, or chronic pain syndrome. This happens because some doctors fail to consider Tarlov cysts as the underlying cause of the neurological dysfunction and pain. The dismissal and misdiagnosis of symptomatic Tarlov cysts can lead to devastating and life-altering consequences for patients. Delayed diagnosis increases the risk of progressive nerve damage, leading to chronic neuropathic pain and functional impairments such as bladder incontinence. Misdiagnoses also can result in stigmatizing labels in health records, unnecessary treatments, or surgeries. This can be considered a form of medical negligence, as patients are often deprived of an accurate and timely diagnosis. The lack of proper recognition impacts their ability to access appropriate treatments, jeopardizing their careers, financial stability, and quality of life. From the beginning, Dr. Tarlov suspected perineural cysts could cause symptoms and spent decades sharing his research and knowledge about them. Tragically, his work was overshadowed by a single phrase in his 1938 paper, "without clinical significance," referring to the cysts found incidentally in cadavers with incomplete medical records. The medical community has had over 76 years to correct their initial misinterpretation of Dr. Tarlov's literature from 1938. Since then, the issue has resembled a sad game of telephone, where the understanding of symptomatic Tarlov cysts has become increasingly distorted. This appears to be a case of knowledge erosion, the gradual loss and distortion of critical information due to neglect and poor transmission. Over decades, the nuances of Dr. Tarlov's research have seemingly been eroded, leaving behind a simplistic and often dismissive narrative about Tarlov cysts that harms patients. Thank you to the researchers and doctors who are choosing to listen to and believe symptomatic patients, standing on the right side of history in addressing this debilitating condition.